think PMDCT is firstly a wonderful opportunity to screen mothers for TB, and there's several studies from India and from South Africa showing that using very simple approaches like asking mothers whether they have TB symptoms can lead to very high yields of active case finding of TB amongst pregnant women, HIV positive and HIV negative. Because remember, PMDCT should also benefit HIV negative women to stay negative. So firstly, to detect active TB amongst pregnant women, HIV positive and HIV negative women, putting them onto treatment, and putting their children onto isoniazid preventive therapy once they're born. The other very big opportunity is to put HIV pregnant women on IPT to prevent them from getting TB. So I think systems like PMDCT that work quite well in many settings are a lovely opportunity and a fantastic opportunity to be asking simple questions about, is there a TB contact, have you been coughing, and doing TB screening. So that's within the antenatal period. In the postpartum period, when babies come for PMDCT follow-up, once or twice a month they'll come for their checkups to the clinic. That is again an opportunity to ask the mom, apart from whether she's well, whether she's had a CD4 count, are you coughing? Is someone in the house coughing? Because a lot of TB in pregnant women occurs in the postpartum period. And then screening that baby for TB. If a baby comes to the healthcare system, if there's a contact or the baby is sick, asking the mom and the baby, seeing them together. So emphasizing the mother antenatally and then both the mom and the baby postnatally. In ARV clinics, I think in my experience, these are excellent opportunities to prevent and treat TB disease. Before we start the ART, we want to exclude active tuberculosis disease, and we'll go start therapy anyway. Children who are HIV positive and on antiretroviral therapy have access to healthcare systems, and once a month when they come for their drugs and their checkups, one could ask, do you have a TB contact? Have you been coughing? And screen for TB. So in our experience, even in community level ARV treatment centers in Khayelitsha in South Africa where I work, ARV doctors and HIV doctors are actually very aware of TB and IPT, and this is a wonderful opportunity to deliver preventive therapy in a more structured way, because there's an awareness of the need for education and interaction with parents and families around taking antiretroviral therapy and being on treatment and taking other medications to prevent opportunistic infections like Bactrim. So to add something else to prevent TB is, I think, the uptake there is, we find, usually very good, and there's a lot of culture of interaction and education with parents and their families around the need for prevention and care. And so paradoxically there, we often find the uptake to be far better than in HIV negative children who are recent household contacts. The current guidelines, WHO guidelines and most national guidelines, say any child that's suspected of having TB should be tested for HIV. Any child that's HIV positive should also be tested for TB. What we normally find is better implemented is that people diagnosed with TB are also tested for HIV. So someone who goes onto TB treatment, in the TB treatment registers, healthcare workers are supposed to check off whether they've been tested for HIV and whether they've had a CD4 count. Also children. The uptake for children has been much lower than adults, because guidelines say people, and often healthcare workers forget that children are also people. But the second question really pertains to HIV positive individuals and screening them for TB, and that implementation isn't always as regularly monitored and not as good as it could be. But the TB HIV integration focus has become much stronger in adults, and there's a real need to move that forward in children as well. So I think that's a real gap and opportunity for operational research and health system strengthening. So I think in countries like sub-Saharan Africa, 1 out of 4 or 1 out of 3 women, pregnant women, are going to be HIV positive, and that prevalence is going to be lower in some settings, but overall it's really high. So HIV in pregnant women is a reality, so obviously cannot be ignored, and HIV needs to be an essential part of maternal and child health focus. TB, on the other hand, has been somewhat less obvious, and what's been very, very ignored is the fact that TB is one of the leading causes of mortality amongst pregnant women, HIV positive and HIV negative pregnant women. So realizing that we are currently not on track to achieve the Millennium Development Goals, if we think of child and maternal health and infectious diseases, maternal health, child health and infectious diseases, by focusing on pregnant women and their children for general health, but also for malaria and TB and HIV together, is probably the smartest strategy we could implement to achieve these goals. There are relatively well-established healthcare infrastructures that could be used to include infectious diseases, which could have massive, massive impact on morbidity and mortality for women and their children and their families. So I think that one should be careful one should build on the well-established healthcare structures that have been developed, but they should speak to each other and they should be integrated. So I think integration of child and maternal health care, specific focus on including TB and HIV, is going to be very strategic, and these are really low-hanging fruit where we can have a massive impact for child and maternal health, and probably will be highly, highly cost-effective, because these women and children are already accessing services, and services are there. We're just making more. We're just integrating the opportunities to be able to deliver more effective packages of care. GeneXpert's obviously very exciting. It's wonderful to have a new tool for the first time in ages. I think one of the main challenges, well, firstly, there are no data published in children yet. So WHO has made recommendations about the use of GeneXpert in some populations, and they've extrapolated those data to children. I think as a pediatric community, we want to embrace any new diagnostic tool that could potentially help children and help diagnose them more rapidly. One of the major challenges, however, is the fact that the gold standard of diagnosis in adults with pulmonary TB, which is culture, is not a very sensitive gold standard in children. So maybe 1 out of 3 children with pulmonary TB will be culture positive. And that means that if we implement a new tool that's almost as good, say it's 80% as good as the gold standard, that means that we may be detecting 80% of the third of kids that could be culture positive. Now that could be seen as not good enough, but I think it could potentially impact on at least making a confirmed diagnosis in a significant proportion of children, and not just giving presumptive therapy and treatment, and actually knowing that we are truly treating kids with bacteriologically confirmed TB, even if it's only a smaller proportion. It may encourage healthcare workers to get sputum samples in kids, because we can do it on sputum samples in kids. It will tell us about drug resistance in children and help to manage them appropriately, so if we don't put them on MDR treatment if they don't really have MDR disease. And then I think finally getting better estimates of TB that's bacteriologically confirmed, that could be useful. I think we have to realize that the test is not designed for children, and children per definition usually have porcibacillary disease. So I think in summary, we will be able to confirm a diagnosis in a significant proportion of children. That will be a small proportion, but a significant proportion of children. Where I think it would be interesting to do more research, and that's obviously very much needed to do both the clinical research and the operational research, is to see whether having a more rapid result will actually impact on the management of children. Because if you take a sputum and you can do point of care GeneXpert at a clinic, and it's positive, and you can start a child on therapy on the same day without having them come back a month later after a course of antibiotics, etc., that may really impact on morbidity and mortality. But I think we need to see the data, and we actually need to generate the data. We obviously are excited about any new tools, but a really important message that should come out is that new diagnostic tools that are developed should also consider the needs of children up front, which is having low yields of organisms in their culture and a real struggle to actually produce sputum. So we do need diagnostic tests that are going to be more child-friendly and child-appropriate. Some of the major challenges I would call control and not elimination. I think maybe the pediatric community is somewhat more modest about its goals, recognizing the challenges. I think some of the challenges were highlighted that there's been limited focus by WHO national TB programs on children. There's been systems neglect that is being addressed, but it's going to take time to address these needs. There's limited technical capacity on the ground, and that's a theme that constantly emerged. Yes, there are guidelines, but how do we actually go about implementing? Health systems that actually are trained to be child-friendly. There were major gaps highlighted in research for new tools, and those are drugs, vaccines, and diagnostics. The other major point that was highlighted was the fact that TB in children is a global disease, and we saw data from Europe where almost 40,000 children were diagnosed with TB in the last 10 years, which is astounding, and most transmission actually occurred within Europe. And the challenges that were highlighted sound very familiar to me as a South African, and that there are major problems with pediatric TB in the US that has also been neglected, so that pediatric TB is really a global entity. We need to join forces as a global community. Two of the other key messages that emerged were the need for partnerships, need for advocacy, and the need to join forces with scientific health reporters, with health advocates, with industry, with funders, academics joining forces, the TB and HIV communities joining forces to really impact on childhood tuberculosis, and collaborate as much as possible. And I think the final theme that's I think hopefully emerge is that finally people are starting to realize that childhood tuberculosis is important. Now's the time to act, and it's a major challenge to people in the field to now come to the table and start delivering. Yes, people are now more aware, but yes, what are the next steps? And can we actually show in 5 years' time that we've set targets, we've achieved targets at program levels, that more children with TB have been detected, more have been managed, more trials have been done for TB drugs in children, doses that are appropriate to children for pediatric drugs have been developed and actually given, contact tracing is happening, that we're actually achieving some of these targets. I mean, not just talking about this neglected entity, but we're actually showing that there's real progress made in the field, both for research and for program implementation at a sustainable level, and that countries start taking responsibility for their children with TB. So I think those are the themes that we've realized. Yes, there are gaps. There's much that we can do. There's much that still needs to be done. But as an international community, we need to start delivering.
And is that, in essence, what the call to action?
Yes, absolutely. Yeah, and that's very broad and inclusive, so as not to preclude anyone from signing on.